Going back to the evidence-based dentistry, you have mentioned today that like in vitro, of course, is the lowest in the ranking.
Actually, the lowest is my opinion.
Yeah, that's true.
Expert opinion is the lowest.
All of our opinions are the lowest. And I want every dental student to hear that clearly.
What did you say?
All of our opinions are the
Yeah,
lowest.
opinions are the lowest. Now, hopefully, our opinions are based on evidence, and
Yes.
that's why when I give a lecture, I use a template of what is supporting that.
Hola a todos y bienvenidos a un episodio más de su podcast Dentíficamente Hablando, un podcast donde conversamos sobre literatura dental y hablamos de todo un poco de vez en cuando. El día de hoy se nos une de nuevo un colega que ya se está volviendo común, ¿verdad? Un colega que además de ser amigo excelente en la conversación desde el punto de vista de la periodoncia, el doctor Salazar. Hola, ¿cómo estás, Ernesto?
Oh, good. ¿Todo bien? ¿Cómo estamos?
Bien. And also today, y hoy también tenemos a un más especial todavía, a un invitado más especial, es el doctor Sadowsky. So vamos a tener el día de hoy el podcast también en inglés. Los invito de nuevo a que se utilicen las opciones de traductor en las diferentes plataformas, acá en YouTube, Spotify y demás. And we will start the podcast soon. Vamos a iniciar el podcast con el Dr. Sadowsky. So welcome, Dr. and Professor Sadowsky, to your podcast, Dentíficamente Hablando. It's a pleasure to have you here and an honor. And thank to Ernesto. Yeah, welcome to the podcast. How are you today?
Just great, and thank you for your interest and inviting me. I so appreciate it.
Yeah, thank you again. And so to start, can you tell us a little bit more about your career on the Pacific University of the Pacific in the Preventive and Restorative Dentistry Department? And yes, what have you been doing lately? So,
okay, so I think I'll start from a beginning inflection point when I became a general dentist, and for 7 years I was practicing, and at the same time I was taking some continuing education courses. One of them was a monthly course in prosthodontics, and it became a central focus of mine because I started to bond with the other attendees and also with the instructors. And at one point, I realized that I wasn't that happy with my outcomes as a dentist. Sometimes I would have to remake things, and I mean, it was getting to the point where Thursdays and Fridays were for remakes, and the rest of the time I was starting work. And so I went to the director of the course. His name was Alex Coker, and I actually shared with him that I thought I would quit dentistry. And he said to me in a very casual way, he said, "Okay, well, you can do that, or you can get better." And I said, "What do you mean?" He said, "Well, you could matriculate into a prosthodontic graduate program." And when he said that, it resonated so much with me because I was yearning to develop some expertise, and I had great admiration for him. And the reason is because he had some traits that were extraordinary. And this began my path to a place where I felt my opportunities would blossom, where I would have so many different options in terms of meeting my personal goals and making a contribution. So the first thing about him that was so exceptional is that he had such an investment in people that he taught. So when I went up to him, I had his total focus in that moment. He was present, and you could tell he was invested in my welfare. Second of all, he was very transparent when he presented materials, even presented on his failures. I remember the letter that he made public of one of the patients that hated the way she looked. Said she looked like an old bag, more like a horse than a woman. And, so, because he did a lot of denture work. And so that was, to me, such a human and real, genuine way to teach. And it opened me up in terms of my own transparency. And the other thing about him is he was exceptionally creative, not only as a teacher, because he would bring in input from different countries and different disciplines that were fascinating, but he also was so creative in terms of how he dealt with patient management issues. He actually wrote benchmark articles called Difficult Denture Birds. I don't know if you've ever heard of it, but what he would do is he would liken patients to different Audubon classifications, such as mine were mallard. Now that mallard is a duck, okay, but he called it mine were mallard. And that is the denture patient that comes in because she's not happy with her denture, but you make her a new denture and she comes back constantly saying, well, I see what you did here, and I see, it is better in some ways, but mine were a little bit more like this. And you make a little adjustment and send her home, and then she comes back the next week. The same thing. Well, yeah, that helped a little bit, but, mine were, I had a little different shade, or mine were a little bit flatter in this area, or my palate seems like it's more crowded now. So it would be like Chinese torture, and, over and over again adjustments. And so he was so clever in capturing these dysfunctionalities of patients. He would talk about the patient that would flatter you to death, saying that, oh, you're the savior, that's why this patient came to you. And then little by little, when he found out that you did not satisfy all his demands, he had a mace or a weapon behind his back where he would be ready to assault you. And this was called karate hawk. So, he had this clever way of displaying his experience with dysfunctional patients, and really as a guide to have what I call an early warning system, because patients often go through what I call progressive disclosure of their dysfunction, meaning it doesn't come out right away. And then, and if you don't take time in the beginning for your diagnostic regimen, you can get locked in to the treatment because you can't abandon the patient because you do some irreversible things, and then you really don't have a good out. So his patient management skills were something that were especially acute. And then as a teacher, not only was he articulate, but he also was very funny at times, and he would bring jokes in. He realized that he would have to be entertaining as well as educational. He also was very frank with those that engaged him. In other words, if you asked him a question, he might say, well, that question is not a sincere question. What you're really asking is this. And he would not worry about the reception because he always would say it from a paternalistic place. If he knew that you were sincere, he would always be a weather vane for the truth. And you could depend on that. Now, the other thing about what I realized is mentorship. And that is, some people say, oh, I was so lucky because I met this person. I met my mentor. That is not what the phenomenon is all about. It's actually like an enzymatic coupling. There's some background noise. I don't know, maybe you can tell some to mute. Do you hear the background noise?
I don't.
That's better.
do. Okay, thank you.
Okay. So what I'm talking about is what I call the law of attraction. And that is when you have a center of gravity where you are gravitating towards a need for expertise, you will find a mentor. And a mentor is actually looking for someone who is open to have this guidance. So that's how it works. And you don't have to worry, oh, I hope I meet the right person. No, if you're sincere and you want to refine your craft, you will find the right person. And that person will open up all kinds of avenues, opportunities, doorways, which will then allow you to find what your particular gift is. It may be in writing, it may be in teaching, it may be in, I would say, professional societies and outreach. There's all kinds of spokes to this wheel, and that can be facilitated by a mentor. So, in my case, I have had a tremendous amount of reward in the writing area. I enjoy it, and also in finding unmet needs and filling them. And we'll talk about those in a little bit. But when you have a chronic problem that hasn't been solved, I think that's a gift. That means that's where you go and do your work in order to make a difference.
That's true.
I could say that I can see a lot of those adjectives that you use to describe your professor in yourself. So I would like to ask you that if you were not have been a professor and a prosthodontist, would you have done something different with your life?
Yeah, so, one of the things that I know about myself is I enjoy writing, because I think writing, in a way, when you think about it, is a refinement of your thinking. You have a chance to take your thoughts and to galvanize them in a way that would be the most effective to communicate those thoughts. When we speak, sometimes we say, oh, gee, I wish I would say it this way or that way, right? But with writing, you have the ability. You can proofread and proofread until you're happy with it. So it takes a certain kind of onus off of saying, well, it's not my best or whatever. No, it can be your best. And I find creativity in writing is something that sometimes comes outside yourself, which is such a phenomenal experience when you start to access knowledge and also methods for communicating that you never thought about. So it is a collective that you access, and I find it tremendously stimulating. So writing would be one of them. I've often thought about acting as well, which I would enjoy. I think teaching involves a certain amount of acting. And when I was little, I thought for sure I'd be a Major League Baseball player, but my talents belied that.
Oh, wow. The wide range of different professions there. So very, very interesting. So what kind of, writer would you have been? Do you have like a specific...
Yes. So
that you enjoy?
I mean, I obviously, I've written in scientific literature. I've written or edited a book on treatment planning, but if it wasn't in this domain, I think it would be in a reflection of what I've learned about observing how to develop your grace. That's something I'm interested in, because the process of becoming a whole person, of someone who hopefully is a healer for others and for yourself, is something that I think is transmittable. So it would be something of interest to me. And I still, now that I'm so-called retired, I have time to devote myself to areas that I think could make a difference.
So, speaking of things that you have written, we were reading an article that you wrote, which I will say the topic is very controversial, if you will, because it's a question. And the question is, are implants better than teeth, or are teeth better than implants? And we were wondering if we can discuss the article right now with you, if that's okay with you. So when we were reading this, I mean, we discussed it before. I mean, you and me, and then I discussed it with Juan, and that's why we came up with the idea of having you here. Maybe we can discuss it and
Sure.
and maybe come up with some kind of explanation about it so that everybody can see it. Because you compare the biological and the mechanical difference between the teeth and the implants. And actually, everybody's doing dental implants right now. It doesn't matter that we were having this discussion the other day with Juan. It doesn't matter your training. It doesn't matter if you did one only implant and that implant turned out to be a good success, and then you come to your private practice and then you charge people a lot or not a lot, but you're not a healer. You're a business person now, like you said. So what I'm trying to ask is, do you think the dental implants are more of a business than a treatment planning in everybody's hands?
Okay.
Treatment option.
All right. So you're intimating something that is a result of the controversy, and that is, I would say that there's a conflict of interest to accept the evidence. Now, why do I say that? So there is a conventional wisdom that it's best to over-engineer implants based on the myth that implants are like teeth, except they don't have a periodontal ligament, so they cannot mediate forces well. And that is a complete myth because it decries the histological evidence that we know. And when I was at Stanford, I did some research, and it was a great gift because I realized what is happening at the level of the PDL when forces are going to be exhibited or placed on an implant prosthesis. And what do we know? It's quite different than a tooth. Because if a tooth is taking the stress of about, let's say, 7 or 8 megapascals, it then does not handle that force well. Under that, it mediates the force well. But when you get to 7 and above, what happens is that there is initiation of inflammatory cytokines, of other, let's say, tumor necrosis factors. These are all ligands that actually will lead to osteoclastogenesis. So the PDL is quite good, but it has a rate-limiting factor, and that is with so-called excessive forces. Now, what are these excessive forces? Oh, well, they are balancing interferences, like on number 15. That can cause more force than the PDL can handle. And do we see any evidence of that? Yeah, we've seen actually bone loss when you have a significant balancing interference on a natural tooth, right? We have. But what about implants? They don't have a PDL. Oh, wait a second, it must be a lot worse. They don't even have that help. No, it's a lot better because the fatigue failure of the bone around the implant is at least a ceiling of 3 times 7 megapascals. So what is this all meaning? What it means is that our intuition is wrong, that we have to protect implants. We better splint implants. We better not have crown to implant ratios of 2 to 1. We better not use short implants that aren't splinted. We better not use cantilevers, especially 2-unit cantilevers, especially distal cantilevers, because that's going to be tremendous bending. And look, any time that Bo Rangert would show you a computational geometric diagram that you're going to be doubling the stress on an implant. Why would you ever do that? So no, you better have 3 separate implants rather than a 3-unit fixed partial prosthesis on 2 implants or a cantilever. It's 100% more stress than just having a 3-unit fixed prosthesis. So here we go. That's all coming from what? In vitro studies. Where are in vitro studies on the hierarchy of evidence? Anybody know? Way down there. Why? Because they're talking about relative forces, not relevant forces. Now, what's a relevant force? Well, it's the same thing when you go to the gym and you work out. Okay? Now, are you going to go to the gym and say, well, I don't want to lift any heavy weights because it might be too stressful? Oh, wait a second. Up to a certain point, hyperloading is good, right? In fact, we find out with implants that if you have 2-to-1 crown to implant ratio, you get, you get an anabolic response in the bone, just like you would when you work out with weights. You actually get a better response with 2-to-1 than you do with 1-to-1. That's all very intuitive, isn't it? No way. So what's happening here? Why is this not being put to rest, this business that, well, you know, in my practice, I'm careful about this or that? And why do I talk about a conflict of interest? The conflict of interest is over-treatment. Because if you're concerned about short implants, you might, well, I think a graft would be good here so I can make a longer implant. Then I don't have to worry about the crown to implant ratio. Or maybe what I'll do here is I'm not going to do a cantilever. That's not really the Cadillac. I'm going to put 2 implants in, and I know that that's the best. Do you know that? Do we have any evidence by De Angelis that shows that it's the same success? I'm not talking about survival, success. You know what that is. That is due to complications than having 1 implant per tooth in a 2-tooth space. So here's the thing, guys. When are we going to look at the evidence and then throw out our biases, especially if our biases are feeding us financially? Okay, does that answer your question?
Absolutely, 100% what I had in mind.
Actually, I wanted to know, like, for example, based on this, idea. So, what would you recommend to remove those biases on the dentists?
Yeah. So you have to understand there's 2 avenues to change this, and we'll get into a funny other avenue. But first avenue is dental education, right? Because when you get out of school, a lot of your theories are formed, right? So you have to have a revolution in terms of the curriculum and protocols for teaching. And there has to be a consensus by the faculty. We weren't even able to have that at UOP. Well, it maybe speaks to my own impotency or obstinacy on the other side. But the bottom line is, this is tough because there are naysayers that aren't willing to look at the evidence and the quality of evidence and the body of evidence. They might find one, they'll quote a study by Rangert and say, oh, we're doubling the stresses here, don't want to do that, without even knowing what the fatigue failure of the bone is. So that's number 1. Number 2, it's continued education, okay? And then, there's a lot of dentists that, especially millennials, they say they'd rather just kind of get it from YouTube or, something quick and easy, which is not necessarily going to represent what we're talking about. The third thing which has emerged is ChatGPT. Okay? And this is what I find so fascinating because I had a conversation with ChatGPT just a couple days ago. Yeah, I asked them about, well, what do you think about 2-to-1 crown to implant ratios? And what do they say? Well, this is a problem because with that kind of mechanical load, you're going to have bone loss, and that this is going to be a complication of that. And I said, well, what evidence are you drawing on for that conclusion. And they gave me 4 authors. Every one of those authors came to a different, opposite conclusion, that it did not cause marginal bone loss. And so I go back and I say, you know, there is some danger in this misinformation, because if it is promulgated, what happens is that the dentist will then overtreat the patient based on that. In other words, grafting, longer implants, splinting, all those things in order to override this. And you know what they said? They said, okay, I understand what you're saying. I can see where this could lead to overtreatment. Then the question is, when you go back a couple days later, what is ChatGPT going to say? Well, you have to understand that the basin from which they draw, GPT draws their information, is from the internet. It's from text. It's from a whole collection of things. There's no hierarchy. It says, oh, yeah, well, when I look at this article, I know that it is more rigorous. And it's really interesting, because in the beginning, when I was so-called arguing or debating with ChatGPT, they first said, well, yes, you could be bringing up some nuances and differences in terms of populations and methodology and study size and all that. And so the first response was to defend. And then finally, when push come to shove, had to say yes. But then the question is, does it change the terrain? I doubt it. So in answer to your question, Juan, what are the avenues to change this? It has to start in the dental school. And then it has to then infiltrate into the continuing education area. Okay?
Thank you. Yeah,
But
I agree.
something, I'm sorry.
No, go ahead.
But a lot of the things that you said are actually things that we see like today, especially with my generation, like you said, because in the younger generations it's even worse, because back then when I was in school, you at least had to read, even if it was on a computer or whatever. But yeah, it's true. But now, like you said, no, just let ChatGPT do it. I don't care. Let ChatGPT answer for my essay, whatever.
Okay. So here's the question I have for you guys. You just identified an issue there. What would you do about it? What are your ideas of what to do about it? And then I'll tell you what I'm going to do about it. And I'm asking for a reason, because this is the jumping off point that would make both of you more powerful to make a difference. And that's what you all get excited about, believe it or not. So what are you going to do about it?
That's a very hard question, I think, maybe. I don't know.
It is a very difficult question.
Right. Well, you don't
But
want the easy.
it is an important one, because, it's, this is a new technology. And as a new technology, we should learn how to use it in the benefit of our, in this case, our career, and in the benefits of the patient. So I wouldn't say to not use it, and I will try to find the way to, help my colleagues and maybe students as well, to learn how to correctly use it in benefit of our treatment plan, or the treatment page, or the patient. That would be, I think, the best option.
I agree with you, but they said the same about heroin when it came out to the market. It was going to cure tuberculosis, and see what's going on with it right now. I don't know if it's going to be like that, but what I can say is that we are getting lazier by the second. So the other day, there was this person asking me for, I don't know, help with it was something simple, to write something up for her. And I did. Little I knew, it was a homework that the person had to do, to give it to one of you guys. It's the same thing that they do to ChatGPT with ChatGPT. So I didn't read anything. I don't know anything. I just can repeat, like as if I was some sort of parrot.
Yeah. So here's the thing about that, Ernesto. What happens when you move in that direction where the ends justify the means? You lose the pleasure of the work. In other words, there's no gratification when you're co-opting this from somebody else. And no matter what the guile is or whatever, on the deep level, there is no satisfaction that comes from that other than just passing by. It's a surrogate satisfaction. So eventually, there is something there that is always wanting some fix, some type of solution, because it never will satisfy a person. And you don't have to worry about, well, I did this for them and I found out they're doing that. Life will teach that person.
Yeah, that's right.
But what I'm suggesting, when I found this out about ChatGPT, exactly how derelict it was in terms of the interpretation of the evidence, I decided I'm going to write an article to the GPT, and I'm going to talk about, these are my questions, these are the answers, okay? And so this is what you could, when you're writing an article, this is what you could or could not depend on. So that's how you can amplify the stage in which you feel like there is some imbalance.
Yeah, that's
Okay.
true.
But coming back to real life,
Real life.
ChatGPT will not. I mean, with a patient and myself doing an implant,
Right.
and yeah, that's what I mean. So ChatGPT will not tell you to do an impactful decision when you're making either an extraction or a periodontal regeneration or an implant placement, because I mean it will probably say, yeah, the forces applied to the implant when you're chewing, biting, or whatever are better resisted, like in comparison with a tooth. But I would like to know your thoughts about periimplantitis regarding this, because so we're talking about ChatGPT and we're talking about all of that, but I'm not sure if I'm explaining myself correctly, because I said periimplantitis and the forces that are applied and the cleaning of the crowns and all of that, because you cannot regenerate an implant.
Okay.
You can regenerate a tooth.
Okay, so here's the thing. This problem with periimplantitis comes out of the work that was published on teeth versus implants. And that is that an implant suffers by a poor comparison with teeth because of, number one, look at the gingival complex. The attachment apparatus is so delicate. It's nothing like the grid-like oblique fibers, Sharpie fibers that you see in a tooth attached to the cementum. Okay, you don't have that. Number two, the vascularity, the plexus that you have available from the PDL is extraordinary. Got nothing like that around an implant. Okay, you also have very often a problem with where the microgap is, which is close to the bone. With an implant where you don't have this kind of nidus for colonization around a tooth. So you have a number of problems. Biologically, there is no stem cell regeneration. You don't have like fibroblasts that are pluripotential that can, make osteoblasts, cementoblasts, and clonically themselves. You don't have the mast cells and the macrophages that are at the ready to take on the biologic insult. So all this means what? When you have an invasive vector, biologic vector, you usually get about twice the downgrowth of the inflammation due to the fact that you don't have the defense, okay? And then you don't have a predictable treatment for this problem. Okay, so again, when you don't have a predictable treatment, what is the next step? You make a difference by looking for an answer. But back to your question, what about, what effect does this have on the fact that implants are being placed more and more, and we find that we have at least 22% incidence of periimplantitis, and maybe after 10 years it's like in the 30%. Of course, you have close to 50% peri-implant mucositis. So has that been enough to deter people from salvaging natural teeth, compromised teeth. Now the question is, well, wait a second. Why would you want to salvage a natural tooth when you can take it out before you lose a lot of bone and place an implant? That's a rational question, right? Well, wouldn't it be great if we actually had a study like that? If somebody looked at compromised teeth, periodontally involved teeth, in patients that were compliant now, that is the sine qua non. You have to have that. And place implants in those patients and also maintain compromised teeth. And look at it over 10 years. Wouldn't that be a great study? It was done. It was done. You know who did it?
It was done.
Rasparini. Rasparini. Okay? So what did Rasparini find? More bone loss around implants than the compromised periodontally teeth. Okay? So we have the nail in the coffin regarding this idea, oh, better take out a tooth, if it's compromised, put an implant in there. Because a tooth has much better biologic defense. And if a person is compliant, you can capitalize on that. If they're not, then it starts making everything kind of even, So there you go. That is the treatise that I have in terms of how to look at being conservative.
Yeah, I want to go back to the the discussion on the article,
Okay.
Because in that article you discussed this antes law, which is like an historical concept. I think it has almost 100 years now, I think, and in relation with the implant supported prosthesis and the tooth also prosthesis. So, in your in your experience, how has modern research shifted the understanding of this principle? Is it still good? Is it still applicable to the
okay.
natural teeth dentition, but also the implant supported dentition?
So first of all, it's somewhat an empirical guide. Okay, it was never scientifically established.
Yeah, I know.
So here's an example. Andy's law is that took the total square centimeter area of the root and of the tooth that you're going to be replacing, and is it being compensated by the abutment or abutments, right?
Yeah.
So if you have let's say a molar, okay, and then you have a bicuspid, and so you added the total square centimeters of radicular area of those two, could it support another molar? Yeah, it could, right? Because if you take one molar radicular area and you have another one, then you also have bicuspid, that works. That's a 3-unit bridge, from 2 to number 4, right? But what about if you had, let's say, a second bicuspid, and you want to put a cantilever on the distal of that, on a tooth? How would that work?
It wouldn't be.
It's not predictable. In fact, Lindquist and also Terry Walden did studies to show, especially after a period of 8 years, there's about 40% failure rate, and we're talking about tooth-borne now. This is why it's given implants such a bad name, because people still think about teeth. But anyway, the point is, you can see where Annie's law is flawed. But the point that I may have been making in there, and I'm not quite sure the context I was using it, is that Annie's law has been challenged, or let's say it's been pushed to the limits by patients that want to have a fixed restoration. So let's say that they have a canine, and let's say they have a second molar on one side of the arch, and they don't want to wear partial. Okay, so what does the dentist say? Well, I could give you something fixed. I would need to put 3 Ponics in, but you don't have the radicular length to offset that, or area, right? So that would not meet Annie's law, right? But dentists may do it in order to satisfy patients, right? And so implants have allowed us to circumvent those risks, because you could place, an implant in the number 3 and then in the number 5 position, and then you could do a 3-unit fixed partial prosthesis on 2 implants, and you don't have to violate this empirical Annie's law. So that's where implants have helped.
Yeah, and also the cantilevers, it is.
Well, the cantilever is a perfect example of how counterintuitive answers are better than intuitive ones. Because the fact is, if you're not challenging the fatigue failure of the bone, then you are not going to have a problem, even though in vitro on the bench, it looks like the stresses are high. It doesn't matter, because you haven't made them realistic, okay? And so, again, what it leads to is overtreatment, where you tell a patient, this is kind of risky, I'm going to have to put 2 implants in, but I can't really put one in native bone in this, number 3 area. So I'm going to give you a sinus graft, and then we'll be able to give you a good supporting foundation. And that's how the informed consent goes, which is counter to the evidence.
Yeah.
That is a discussion that Juan and I have all the time because, like you said, I'm jumping to ChatGPT again. The discussion nowadays is not based on scientific evidence. It's not even in personal experience. Now it's even worse. It's based on ChatGPT's experience.
Right. Well, that's why I want to do this article, which I think would be fun to do. Just all I'm going to do is I'm going to amplify what our conversation was. And it's amazing. I didn't realize that I'm saying he, this anonymous person, ChatGPT, would back down finally, because he was starting to, prevaricate and kind of say things like, yeah, it's true, some studies may show this, but, there's lots of differences, and never really come to the fact that he is giving misinformation, but he finally did.
Yeah.
And that's something that even Dr. Pajosian hasn't done.
And it's something that it may be improved also in the future. So, going back to the evidence-based dentistry, you have mentioned today that like in vitro, of course, is the lowest in the the ranking.
Actually, the lowest is my opinion.
That's true.
Expert opinion is the lowest.
All of our opinions are the lowest. And I want every dental student to hear that clearly.
What did you say?
All of our opinions are the lowest.
Opinions are the lowest. And hopefully our opinions are based on evidence. And that's why when I give a lecture, I use a template of what is supporting that.
So, my question was regarding that, like in your opinion, because, sometimes we said, in vitro is not the best, or the opinion, or a cross-sectional study or whatever. We all want just clinical trials, meta-analysis, and all of this, but sometimes it takes a lot of time. It takes a lot of work.
So here's the thing. There's 2 important points here. Number one, in vitro studies can help to shape clinical studies, but there's something else. When I worked with John Brunsky, when I was at Stanford, what he did is he tailored his in vitro studies to what histologically we found in terms of the loads that were generated by, certain masticatory forces. So he showed, like, for instance, if you put, like let's say a 25-pound force on a cantilever, he showed that given given that the forces on that would be realistic to the mouth, Okay. And then also he knew what the fatigue failure of the bone was. He could show whether that would be a problem. Now, what's happening in a lot of these in vitro studies, this finite element analysis, they don't bring in clinical measurements. They just talk in relative stresses. And that's what is the problem of going down this road of using it as a guide. But then again, when you, for instance, here's another example. Photoelastic studies have been done quite a bit in implant dentistry, and it shows like unitary prostheses, they have a lot more of what's considered to be these fringes that are so much more colorful and wide than one that is splinted. So you walk away saying, oh, that can't be good, But again, if they don't plug in the forces and the fatigue failure of the bone, there is no way that can be helpful. Another study that was interesting that was done on splinting versus non-splinting was David Gaucher, and what he showed is that there's static forces. If your contacts get too tight, then that causes static force, assuming that that's going to be a problem for the implant. When you're splinted, he says, it's passive. In other words, you can't have it too tight between the teeth. That's why he recommended splinting, without even knowing what these static forces would cause, which is nothing. And then, nobody talks about something else which is so subtle, and that is, let's say that you splinted 3 units together, and you get it back from the laboratory, and you see a little margin on one of the units is not absolutely passive. You can see that there's a discrepancy. How likely are you to send that case back as opposed to a single unit that is not quite perfect? This is human nature, okay? This was something that was purported by a mentor of mine, Jack Preston. We used to call it the Preston paradox, and that is the more units that you have, the less likely you are to reject. Okay? So it gets into castability, it gets into rejectability, and it also gets into repairability. If you have a problem with it, it's much harder to repair, right? So all those things we don't talk about. We just talk about, oh, well, it may be safer for the patient if you splint them, and you don't have to worry so much about the interproximal contact with floss. None of these other things are really addressed. They go below the radar, but they're critical.
In your experience, do you have more splinted implants than individual?
I'm not sure what you mean.
I'm sorry, in your private practice, would you
Again,
do more implanted?
Okay, it's not a. It's like saying, in your experience, do you have more? Do you wear more heavy coats or lighter coats?
Wow.
Well, I mean, it's conditional on the weather, right?
Yes,
So if I say, well, actually, I wear more heavy coats now, you say, oh, well, then heavy coats would be better. No, I'm in Seattle. But if you go to Nicaragua, I would not advise you to do that.
you will die.
Yeah, so that's what I'm saying. So to ask that question, it kind of belies the conditionality of it. The point is that if you have a bruxer, yes, you want to splint. Okay, if you have immediate load, yes, you want to splint. If you have heavy grafting, yes, you want to splint. And maybe if you have really low quality of bone, that's somewhat questionable, but these are, and also tilted implants, those are indications for splinting. It's not a thing, well, do you more of this or more of that?
I love your response because it speaks of the evidence that is based off your work.
Yeah.
It's not like going to. That's why we have this podcast, because we want people to understand that our work is, of course, based on your experience, but there's scientific evidence based decisions. So you don't come up with I'm inventing cold water. No, you're not. It's written down. Like you said, Rasparini, Tonetti, Cortellini, they did marvelous study comparing bone loss around periodontally involved compromised teeth versus implants. And yeah. So my next question to you will be, what will you say Are teeth better or superior than implants or vice versa?
Yes, there's a third answer, Ernesto. What do you think it is?
I don't know.
Right. The answer is yes. Teeth are superior to implants, and no, teeth are not superior to implants. They're both true. So they are superior biologically, they're not superior mechanically. It's as simple as that. And all that has led to overtreatment when you don't use that as a baseline understanding.
So on that idea, what would you recommend to young dentists when they have this decision to make whether to save that teeth or place an implant?
Yeah. So that's a good question. It has to do with a number of things. It has to do with the operator, the patient, and the intervention. Okay, so if the patient is compliant, okay, and that means that I'm not talking about born again religion overnight, that you have established that the patient, if they were recalcitrant in terms of hygiene, that they now have definitely changed their habits and they are committed to coming in on a regular basis, then that patient is in a new category in terms of so-called repairability of that problem. And if you have a periodontist that is assiduous and is going to track that patient, then I think that relationship could be very fruitful. On the other hand, if the patient is showing that they're not improving, they take an ATP and it's still very high, even though they say, yeah, I'm doing this, you don't see the evidence of it, then you have to tell them that the wonderful resilience of a tooth, they're not capitalizing on. Okay, and it's up to them.
It's up to them, yeah. And even for that, there is an article written by McGuire and Noon that it speaks about prognosis.
Okay, and what does it say?
It says that, for example, the prognosis of a tooth is based off of the interproximal attachment loss, bone loss, the age of the patient, the compliance, and it speaks the same about dental implants. So are you going to sacrifice it? Well, based on this, that McGuire and Noon say.
So here's the thing. At the same time, you know that a patient that has periodontitis and gets an implant has 25 times the incidence of peri-implantitis. What? Yeah. So they're already in a spot where it's kind of between a rock and a hard place. If they're not going to improve their care, their ownership of their mouth, so to speak, then either way, it's not a rosy picture. So you need, in the informed consent, to tell them, okay, I can see this, you're not doing well with this. We'll just put an implant in there. And you give them, you intimate that that is the panacea. Quite unlike that, they are in a situation that's more highly likely to fail.
Yeah, we have to work with them.
Yeah. So look, it is always on them. Okay, they have to understand what the stakes are. Too often they give it up and say, okay, it's up to you. And then when there's a failure, they say, you did this to me. And you know what? There's an enabling that goes on because a lot of practitioners, they take that on. Okay, I failed, I should have done this, without identifying what the patient's responsibility is. This happens at school a lot of times because we should be guaranteeing things if the patient comes in every 3 months. But the patient comes 2 years later and they have, marked bone loss, and then we feel bad, and then we go ahead and we take it out, we replace it, without having any contingency that the patient was supposed to come in on a regular basis. This has to happen in private practice also.
Yeah, and on that point, it's very hard to navigate that because the patients sometimes do not collaborate, or they have this sense that it's our job to make it
Okay,
100%
so Juan,
or something.
here's the answer to that. I love the ATP test, which is it's an acetogenic load evaluation of the patient. And if you tell them, okay, I want you to dry brush twice a day along with your regular brushing and flossing, and come back and we'll go over it, and then do another test. And if it's still way above 1500, you say, this is not getting you what we want. And so go over it again. And if they are not complying, say, I can't work on you. Now that means you're ready to give up the patient. That means that you don't have a conflict of interest, right? So too often you want to treat because you also want the productivity. But at the same time, you don't realize that that can come back to haunt you and the patient because they're not a candidate.
Yes.
And it will erode your practice productivity dealing with failures.
Yes, that's true.
But you don't think about that at the time. That's down the line.
Yeah.
There's a saying for that in Spanish, or I don't know if it's only in Nicaragua or if it's an international spread, that it says it's bread for today, hunger for tomorrow.
Yeah.
So can you share with us about your new projects that you're doing right now?
Okay, so there's a theme of what I've been saying, Juan and Ernesto, and it is, what are the unmet needs? And how can we play a role in moving in that direction? When you think about it, it was Brannemark that actually started this cord. Okay, it's not, the spectacular serendipity that he couldn't remove the titanium ocular chamber from a tibia of a rabbit. That wasn't the big deal. The big deal was the application outside his discipline, relaxing the boundaries and saying, oh, for the complete denture, mandibular complete denture amputee, this would be amazing. He was an anatomist at the time he found this out, and later, orthopedic surgeon. He wasn't a dentist. Okay, so when you can identify a need that hasn't been met, that's where we get excited. And for me, I read an article in the New York Times, a few months ago, about the placenta and how that can be used for healing. Okay? And it's because obviously it has stem cell capability, and it's a very low on the immunogenic titer. In other words, it doesn't cause an immune response. It's discarded. It's not something that we have to hijack. So what I did is I looked up on PubMed and I found an article that talked about using placenta-derived materials, chorion amniotic type materials, for wound healing. And so I called this woman. Her name was Gorsuska, her last name. And the way I called her, when you read an article, there's a corresponding author, and usually it's an email, but it was a phone number. So I call the phone number, she answers the phone. And I said, hi, this is Dr. Sadowsky. I was I was surprised she answered. And she said, oh, I answered the phone because my brother-in-law has the same name as you. So this is the beginning of what I was wanting to talk to you about when we were discussing how once you make connections in your area of expertise, things start to open up in terms of what we call serendipity. I just actually published an article on serendipity. It was not an article, it was an editorial in JPD. You can look it up online. At any rate, so this was serendipitous that she answered the phone. We started talking about her work. And then I went to University of Washington because I wanted to start using the same material that they use. And it's turned out they needed to have some evidence with clinical studies that this could actually affect bone loss around implants. And so then I did another search, and I found that there was a fellow that did a case report using a similar type. It's a placenta-derived material. His name is Vinay Bide, and I called the company that he wrote in the article about. You know how when you use in the methodology, you have to tell what company you're using and where it was. So I called the company and I talked to them about it, and they were quite excited, and they said, actually, you should talk to Dr. Bide. And so they connected me with a fellow that did that, and now he and I are initiating multi-university site studies so that we can have a RCT, a randomized controlled trial, using a chorion amniotic membrane with GPR for, after you decontaminate an implant site, and then one with a collagen membrane, so have a controlled study. And that's what I'm involved in now because of what I told you. That's the model. Look where the problem is. Look what you can do in order to come from a different place to solve it. I mean, Edison said, find out what the world needs and invent it. That was his saying. It's the same sort of thing. And then, 18 years ago, I was concerned when I was doing implant prostheses that we had tremendous wear on the teeth after 5 years. And so I started to look at how can we provide a better material for our patients. So I talked to a friend of mine who was the dean at the University of Colorado, and he turned me on to the senior research fellow at University of Colorado. And now he and I have been partners for 18 years in bringing a polymer that is high performance, and now we're doing it with 3D printing and inkjet printing in order to solve this problem. So again, this is not, something that only can be done in, rare circles. Anybody can proceed along this line. So look for the issue and find out what you can do to make a difference.
That's a great advice. Ernesto?
You're talking to me? You're saying that is a message for me?
We need to find. Yeah. No. What I mean is we need to find something there.
Yeah.
For us.
Yeah,
in our generation.
Right.
Absolutely.
That's how you make a difference, especially like you say in your generation. Like if you see there's problems in terms of using data incorrectly, then you have to think kind of outside the box. Okay, could we have like a data check? Like another bank of data that allows for real evidence-based delivery of material that will supplant something like ChatGPT. These are the kinds of things you got to think about, because if the millennials or whomever, Gen X, I don't know what you want to categorize, if they are gravitating towards these kinds of immediate gratification sources, why not then supplant it with a good one?
With the real one, yes.
Yeah.
Yeah.
Exactly.
Maybe it's because I met you in person. I had the honor to do so, but probably it's a matter of tone or something. I don't know. But for example, when I say to a person, go and study that, go and look for that, I come across as a bad guy.
No, look. Uh-huh. That's not thinking outside the box, Ernesto. That's
okay.
Outside the box. And
Okay.
Do it like, the old way and do it right. No, that's nothing like innovation. Innovation is, okay, we have a need for something that's instant in terms of reward for what these individuals are looking for. But why not have a platform that works? Okay,
I see what you're saying. Yeah.
That way you say, I get it. You're used to going to Google when you have a question of, whether your wife should shop at Nordstrom or Macy's. We have something that could be much more reliable, and this is going to be it. So anyway, that's the way you have to think. It can't be, we're going to make this generation understand why our generation is better. No way. That's not the gift of that generation anyway. The gift of that generation is to bring us to see if we can find a hybrid or some way where we can make things even easier for ourselves as well as them.
Yeah.
Okay, you have to ask yourself, what's the purpose of what they're gravitating towards? For us, they bring a gift too.
Yes.
Yeah, absolutely. But that's not what I was trying to say. I mean, for example, the other day somebody came to me and asked me, why will you recommend periodontal regeneration in a one wall defect?
Right.
And it was a student, right? And I
Yeah.
said, because there's this new technique that is called the wall technique, and we have the M-Dogain that we can use, and we can use the bone graft as a scaffold. And then next question is, but how can you regenerate that? And I said, okay, because you want to know that, then you gotta know about wound healing, or periodontal healing. So go and read Leonardo Trombelli, and then we can discuss it.
Okay.
So the person thought that I was being a mean guy.
Okay, so this is I think what you bring up is so important. So you got a sense of that he was interpreting as you were being harsh. Is that what you're saying?
Exactly. That is
Okay.
what I'm saying.
So then, because you've raised your antennae in terms of how you teach and what kind of response you get, I would say to that person, again, coming from this place of wanting the best, say, I get a sense that you have some resistance about this, or you think that I'm putting you through some hurdles that are untenable. Is that correct? Am I reading you right? So find out where they stand, okay? And then you can say, they may say, yeah, I kind of feel like you want to put me through the obstacle course in order to get this information. And then you say, okay, let's look at what would be the most efficient, economical way to get this information. Let's see if we can find it. What would it be? Ask them. How would they go about it? Okay? They should come to the same path that you suggested. But you have to be open enough to say, okay, I get this sense that, you're not gravitating towards this, but let's see, what would you recommend to another student?
Personally, I will say,
No.
okay.
You ask them the question. What would they do
Okay.
if they were
Oh,
the teacher?
okay.
So you put them in that position, okay? Now, I've had a situation with actually one of the students when I was working with them, and I had asked them to do something that would be going out of his way a little bit to wax up something after the crown was made because it wasn't quite right. And he said, well, I'd rather just go ahead and reshape this. And so afterwards, when the patient left, I sat down with him and I said, I sense a resistance that you have to go the distance in this case. And he said, what it is I'm always very interested in being efficient. So I want to make sure that I'm not wasting a lot of time. I just want to do things in a timely fashion. And so I said, what you lose by always wanting to be efficient is the excellence that comes from doing some things out of your normal path. And so what the fascinating thing is, he recently asked me for a letter of recommendation. Okay? Yeah. And so I said to him, okay, please send me your feedback about our interaction together in the clinic. I didn't say anything about it. I want to hear what he has to say. Now, if he said to me, I learned something about what you said about going out of your way for excellence, then I would say he learned something. But if he doesn't mention it at all, then I'm not going to support him. Because
The nerve.
and only because I see it as a critical feature in terms of being a team player and someone that's ready to sacrifice in order to have excellence. And I also shared this with one of the other faculty members that found him somewhat pig-headed in terms of he knows the way, kind of thing. Anyway, what I'm saying to you is that teaching is amazing because you have the opportunity to take or titrate the responses you get. And when you get them, come from a place of wanting the best and say, okay, you tell me how or what this means to you and how you would do it differently. So that way you begin to really enter this forum of how to be an effective teacher. Because if you get off the off-ramp when you sense the resistance, then you never really get to how to deal with a full array of students. Yeah, you can deal with a student and say, oh, yeah, that was, I'm ready to do whatever you say, Dr. Reyes, Dr. Salazar.
Yeah, like taking that relationship also to a deeper level as well, I think.
Yes,
it's also important.
It does.
Yeah.
It is amazing because that student, for the first time, wakes up sometimes when you ask those very critical questions because they've never been asked before. Okay? That's where the fun begins. It's just like with what we talked about. When you run into chronic problems, if you go, oh, okay, well, I'm just not going to deal with that. I'm going to work over here, which I have predictability. You never get a chance to widen your influence.
Yes. So we have been discussing for almost an hour or over an hour now. So, we like to.
Paid it 1.5 times, right?
Huh?
I've been paid 1.5 times. Yeah. Well, 1.5 times 0 is still 0, so that's okay.
So, we would like to start closing and finishing this session today. We are open to another, if you're open to join us another time, actually, that would be great. But,
Okay.
I don't know about your
let's
time.
Let's do it in Japan.
Oh, that would be awesome. Yes. Yes, we are going to work on that. Yes. So, before we finish, just one final question. Do you think this debate between the teeth and implant and which one is better is going to end? Or how do you think the future or the evolution of this debate will happen based on your past, and your recent research?
It reminds me of the quote that the presidency doesn't change a man, it reveals the man. Now, why would I say that? Why did I say that? Because this debate reveals the underlying problem. Okay? It hasn't changed it. Will it change it? It might. It depends upon the forces and how we can use these levers to put to rest anecdotal and intuitive theories that are still guiding even at the faculty level of the dental schools.
Well, I think there's no other way better, a way better way to finish the podcast. So that's a really nice thought. So I would like to, thank you for joining us today. Ernesto, thank you again for joining. And
Thank
My
you for
pleasure.
inviting me.
I hope to see you and meet you soon again. So
Awesome.
In Japan, remember.
in Japan, yes. So thank you very
Everything.
much, and I'll see you on the next.
Thank you so much.
Dentíficamente Hablando.
I thought your questions were actually very, very illuminating. So thank you.
Yes, thank you, actually. So, nos vemos en el próximo Dentíficamente Hablando. Bye.